Welcome to The Explainer. Today, we're going to walk through the clinician's journey, covering some of the toughest territory you'll face in medicine. We'll start with a patient's initial presentation, then dive into managing an acute crisis. And finally, we'll cover our ultimate professional duties. So let's get right into it. How do we answer these questions? Because, these aren't just for exams. These are the high-stakes decisions you're actually going to face in clinical practice. This explainer is all about giving you a clear, structured way to think about them. First up, here's our roadmap. All right, we're going to follow this 6-part journey. We'll start with assessing eating disorders, then move into critical safety topics like refeeding syndrome, tackle that tricky intersection of psychosis and the law, look at how to assess risk, and we'll finish up with your core legal duties after a patient has died. First up, let's decode eating disorders. We're going to go way beyond just the labels here to really understand the core clinical features you absolutely have to be able to spot. So at its very heart, what is an eating disorder? Well, it's basically any condition where a person's relationship with food, their weight, or their body shape starts to cause real, tangible harm, whether that's physical, psychological, or just getting in the way of their day-to-day life. Now, this is what I find really interesting. Each of these disorders is all about a different relationship with control. With anorexia nervosa, it's about maintaining this iron grip, this strict control through restriction, which leads to a dangerously low body weight. Then you have bulimia nervosa, which is about a total loss of control during a binge, followed by this desperate attempt to regain control through compensatory behaviors. And finally, binge-eating disorder. It involves that same loss of control, but without those compensatory actions, which, as you can imagine, often leads to intense feelings of shame. So here's the crucial point. While the diagnosis really comes from listening to the patient's story, these 3 investigations are completely non-negotiable for checking their physical safety. We're looking at their vitals, things like heart rate and temperature. We're running an ECG to look for any potentially fatal heart rhythms. And of course, we're checking their bloods for dangerous electrolyte imbalances, like low potassium or phosphate, which can be a huge red flag for trouble ahead. And that leads us perfectly into our next section, a really critical safety topic and, let's be honest, a massive exam favorite. The paradox of refeeding syndrome, where the very act of giving someone nutrition can actually be dangerous. It sounds completely backward, doesn't it? But if you reintroduce food too quickly to a body that's adapted to starvation, you can set off this life-threatening metabolic cascade. I mean, think of it like this. It's like trying to jumpstart a car that's been sitting dead for years with a massive power surge. You're just going to blow the entire system. And this slide just illustrates that chain reaction perfectly. See, after starvation, the body has really low insulin. The second you reintroduce carbs, insulin spikes. And that spike acts like a key, unlocking all the cell doors and causing vital electrolytes, phosphate, potassium, magnesium, to flood from the bloodstream into the cells to help build new tissue. This leaves the blood completely depleted, starving the heart and muscles of the fuel they desperately need to function. So how do we stop this from happening? Well, we follow 4 key principles. First, we have to identify the patients who are at high risk. Second, our mantra is start low and go slow. We begin refeeding with just a fraction of what they need. Third, we proactively give them supplements, like thiamine, before we even start. And fourth, we watch their bloods like a hawk, aggressively replacing any electrolytes that start to drop. Okay, let's shift gears now to another major clinical challenge, managing psychosis. This is a state where reality itself can shift for a patient, and we have to understand how that intersects with some really complex legal frameworks that are there to protect their rights. In the simplest terms, psychosis is basically a break from a shared sense of reality. The 2 big features you need to lock in your mind are hallucinations, which are false sensory perceptions, like hearing voices no one else can hear, and delusions, which are these deeply held false beliefs that just don't change, even when you show someone clear evidence to the contrary. Now, before you ever jump to the conclusion that psychosis is a primary psychiatric issue, you have to be a medical detective first. The red flags on this slide are your critical clues. Think about the timing. A really sudden, acute onset is a major warning. Think about the person. New psychosis in an older adult is super suspicious. Check the vitals. Any abnormalities could point towards a medical cause. And always consider their medications. Have they just started something new that could be the culprit? If you see any of these, you have to urgently hunt for an organic cause, like an infection or a stroke. This table really sums up the double-edged sword of antipsychotic medication. See, most of them work by blocking dopamine, and blocking it in the mesolimbic pathway is exactly what we want. It helps reduce positive symptoms like hallucinations. But the drug can't be that specific, right? So when it also blocks dopamine in the nigrostriatal pathway, it can cause Parkinson's-like movement problems. It's a really crucial trade-off. Okay, this is a distinction you absolutely have to master. The Mental Health Act is all about risk. It's what allows you to detain someone for treatment of a mental disorder because they pose a risk to themselves or others. The Mental Capacity Act, on the other hand, is all about decision-making. It gives us a framework to make a decision for someone who just can't make it for themselves for any reason. It doesn't matter if they have a mental disorder or not. So just burn it into your brain. Risk versus capacity. Next, let's build on that legal knowledge and look at how to structure your approach when you're assessing a patient who has come to you after an act of self-harm. Right? A good risk assessment isn't about predicting the future. It's a risk formulation. It's about creating a balanced picture. We have to weigh the long-term vulnerabilities and the background stressors against the immediate triggers and the dangers. But, and this is just as important, we must actively look for protective factors. The things that are keeping them safe, the reasons for living. It has to be a complete picture, not just some score on a sheet. And this is just a non-negotiable point, especially in UK practice. Your thorough, compassionate psychosocial assessment and your own clinical judgment are the absolute gold standard. A score from a checklist or some scale can never replace a human conversation, and it should never be used to make critical decisions, like whether a patient can go home safely. And finally, we're going to turn to one of the most significant and frankly solemn professional duties a doctor has, the proper certification of death and knowing exactly when you have to involve the coroner. Please do not mix these two up, especially in an exam. Confirming death is the clinical act you do at the bedside, listening for heart sounds, checking for breathing. Certifying death is the legal act you do at a desk, completing the official death certificate. One is a clinical procedure, the other is a legal document. So, the crucial takeaway here is knowing when you cannot certify the death yourself. You have a legal duty to refer to the coroner if the death falls into one of three buckets. Number 1, if it was violent or unnatural. 2, if the cause is simply unknown. And 3, if the person died while they were in state custody. If any of those are true, the coroner must be informed, period. Okay. Let's pull everything we've covered together with a really quick, rapid-fire review of the most critical, high-yield points that you need to take away from this whole explainer. Let's lock these 5 points in. 1. Differentiate eating disorders by their core pattern. Is it restriction, binge compensate, or just binging alone? 2. Remember, the refeeding danger comes from those electrolytes shifting into cells. 3. With psychosis, always hunt for a medical cause first. 4. Know that crucial legal difference. The MHA is for risk, the MCA is for capacity. And 5. Know your 3 coroner referral triggers, unnatural, unknown, or in custody. And we'll end with this question, just to reflect on. And honestly, this isn't something with a simple textbook answer. Balancing a patient's right to make their own choices, even choices we think are unwise, with our fundamental duty to protect them from harm, well, that's one of the most profound and persistent challenges in all of medicine.